Okay, well, welcome everybody to this session. I think it'll be a fun session today that starts at 9 and ends at just after 2 o'clock. We're going to first start with a case, and hopefully during the course of this session people will understand what this whole chip concept is about, what are the best ways to treat it. There are debate sessions as well. It's really an honor for me to be here next to Vijay Trehan, and also we have D.S. Gambhir, who's going to be coming up as well. We also have moderators who certainly can come up here in addition. We have several folks too, and I think it'll be important, especially for the debate and with question times in between, to have people voice their opinions, because there's a lot of opinions in this space and we certainly need to hear all of them. So with that, I think we'll set the stage. My colleague Ramesh Dagubathi is going to present a typical chip case defining the need.
Dr. Trehan and Dr. J. Kirtane, good morning, and great pleasure being here. Thanks to Dr. Srinivas for inviting me. So this is I'm going to set the stage for a chip program by talking about this woman who is 90-year-old. Some of you might have seen this patient's history yesterday, and she Chinese woman living in New York. Daughter is a pathologist at NYU, and she comes in with chest pain, ruled in for non-ST elevation MI. ECG showed ST depressions and diffusely with elevations in AVR. Troponin was high at 45. She was seen by cardiac surgeons, and she was deemed to be a surgical candidate, and because of this diffuse RCA disease, which is heavily calcified, osteal RCA was 90%. She had a prior stent placed in the distal RCA that is patent, but you can see extensive calcification. And the distal left main is the most problematic here. As you can see that there is a tight left main which is involving osteal LAD and osteal circumflex about 95%. So she was initially stable, and an LV-gram was done. This happened actually about last week she came on a Friday, so roughly about a week and a half. So LV dysfunction, anterior anterolateral LV systolic dysfunction, EF is measured about 35% in this patient. So the question is this a patient that somebody should perceive that it is a PCI patient or a bypass patient? So as I said, that she's a surgical candidate. I don't think that there's anything wrong with her to undergo surgery. Unfortunately, while waiting for surgery, she was given Plavix, about 300 milligrams in the emergency room, and hence we did a TEG study, which is a platelet reactivity testing that showed platelet inhibition with the Plavix, and so she was postponed for surgery and scheduled for surgery on Wednesday. And unfortunately on Monday morning she started having more chest discomfort, so 2 days after presentation, and she was given nitroglycerin, morphine, but pain wasn't actually relieved, and in fact actually she developed hypotension after that, and so now she started having significant and severe unstable angina. Obviously the LV dysfunction and the left main, both of them were not going hand in hand along with the hypotension. So this is the kind of patient that we would think that maybe after discussing with the surgeon, and the number one point is I told the surgeon that PCI is a possibility in this patient. So that's something we might discuss later. So I told the surgeon that yes, you are waiting for 2 more days for the Plavix to be reversed, but if patient crashes, can PCI be done in the patient? I said yes, this patient can have PCI. So that's the setup that we had, and after he evaluated the patient, and he said that patient should go for PCI as a heart team approach. So that alone may not be enough, so we did a right heart cath. I showed you a picture with the impella and all that, but before that I placed a right heart cath. Wedge was 32, PA pressures was 70/30, cardiac index was 1.7, so she was rapidly deteriorating, as you can see, and henceforth we proceeded with the PCI in this patient. This is a right heart cath, and an impella is placed, and successful revascularization was done in this patient, and she actually is about to go home probably in a day or so. So this is what I will stop here, and obviously there's lots of discussion that we can have in complex high-risk patients. How do we define a complex high-risk indicated patients? And is it just multi-vessel disease? Is it just hypotension, or is it LV systolic dysfunction? So, but it is a combination of all these three, in my opinion, that you have to think about hemodynamic compromise, patient comorbidities. As we see in this patient had a heart failure. She has unstable angina, non-ST elevation MI, LV systolic dysfunction, as well as complex left main coronary artery disease. So we'll stop here, and I think we'll take any other questions. Thank you.
So maybe before we go to the next talk, what are your thoughts in terms of this space? Is it just a name? And I'll certainly have my own opinion, but why is this important in this day and age?
I think this is just a name because most of us know about that the problem is there, and most of us also know that it needs a solution, and quite a good number of us also know how to offer the solution and have a strong conviction that if you give a solution, then many of these patients will improve. So I think a large number of us have been handling such cases, but not as a program, anecdotally. But I think you guys started this program, if I'm not wrong, 2015, as the name was coined as CHIP. How many of you are aware about or conversant with CHIP? Please raise your hands. So quite a good number of them, say about 15 people out of about 40 or maybe more. So if you look at it, even the top of the intervention cardiologists who are here, not all of them are even aware about the name. So I think it's okay as far as name is concerned, but in the real sense, we are aware about the problem.
Yeah, and I'll touch on that a little bit more in my next talk. Ramesh, the one thing you mentioned is that you spoke a little bit to the surgeon and said PCI is a possibility. And one of the reasons why this whole initiative started is because, especially in the United States, where there are a fair number of low-volume operators, and by the way, the same is true here, in those areas, oftentimes, people don't want to do PCI. I got a call yesterday from somebody who sent me a film and said that it looked like a very complex PCI, so I'm going to start with medical therapy, irrespective of how symptomatic the patient was. And we saw this occurring over and over again. That was the first part. The second part that was going on at the same time was in the wake of Courage, and now you can even add Orbita into that mix. Many people say, well, PCI doesn't do anything good anyway, so then everything gets shunted over to medical therapy. And what I think personally is that, sure, if you have a patient that's minimally symptomatic, then it doesn't really make much sense to do a PCI because they may be fine with medication. But the type of patient that you showed, the type of patient I got called about yesterday, those people really ought to be favored towards a revascularization approach because they can be helped. And you've probably practiced that way, but there are many people who don't.
Right. Actually, I didn't tell you one thing. This patient was seen by 2 interventional cardiologists on Friday after the cardiac cath, and both of them deemed that these patients should not have PCI. So having a CHIP program will help even in our hospital. For example, I was saying that my colleague who was a high volume operator, and he actually on Monday when I'm deciding to do the procedure, he comes and advises me, Ramesh, probably this is not a patient that you should do. The risk of mortality is high in the cath lab. Obviously, we are monitored in the cath lab mortality. And so this is a patient that actually should not have PCI. That was his impression. So having a CHIP program will help us to decide as a group and as a heart team whether what is appropriate. In this patient at 90-year-old, we are not talking about her mortality benefits by bypass surgery 5 or 7 years later, right? And I don't think she will survive that long. We are trying to improve her symptoms right and then and there. Thank you.
Great. So, this is just sort of an introductory lecture into what this concept is. It's good that not everybody raised their hand because some will hopefully be introduced to what it is. And I think the bottom line is to focus on higher risk patients and not the lower risk patients who probably have less to gain. So when we initially started this initiative, and I have to give credit to Jeff Moses in particular, who, by the way, just had his birthday. I'm not going to reveal how old he turned today, but he really is, I think, the godfather of this. Certainly him, Marty, myself, others, we were just talking about this, and many people honestly have done this for their whole career. So this is nothing new to experienced operators. But the idea of sort of identifying it as a specific initiative refers to sort of identify a population that were underused. and to shift our thoughts away from overutilization. You know that in the United States we have a lot of concerns about appropriate use criteria. I've even heard that over here, overuse of stents. And the idea here is to focus on people that could truly benefit from our revascularization procedures. It was to raise awareness in the general and specialized community of this high-risk population, and to enlist collaborative support not only with our colleagues in interventional cardiology, but colleagues in heart failure, colleagues in general cardiology, even industry partners, to sort of get behind something that made sense. We wanted to educate, we wanted to teach, establish best practices for patient selection, for patient treatment, and even post-procedural care, and then importantly, identify research and clinical other initiatives that could help to treat these patients more effectively. So the rule number one is you had to understand the diseases you were treating, and understanding this is very important. I think it sounds very trite for me to say understand the diseases you're treating, but it's important, and the reason it's important is because we actually don't understand it very well. This is a nice slide that's derived from a US registry of patients, where patients are asked, are you having angina? Their physicians are then asked, is your patient having angina? And you would like to think that the correlation between the patient having the symptoms that they express and the physicians identifying those symptoms expressed by the patient ought to be 1-to-1. But it turns out that actually there are many physicians that don't accurately understand whether their patients are having angina, and that may be because they're very busy and they ask, are you having chest pain? The patient says no, and so they say, oh, the patient's fine. But they didn't ask, if you walk from here to the end of the hallway, are you out of breath? Or other questions like that. And so it's important to make sure that you take a good history, because if you can't identify that the patient's actually having symptoms, then how are you going to accurately offer revascularization to these patients? Now, another thing that we see happening is there's variability in care practices. This is a slide from a registry in the United States, to get with the guidelines registry, where on the x-axis are plotted hospitals, and on the y-axis are plotted how frequently medical therapy is used as the dominant strategy for a patient that has a non-STEMI with left main or three vessels disease seen on the angiogram. You would think that there are some patients, maybe very, very elderly or frail, that really ought to have medical therapy, and that's fine. But on the right of the slide, you see there's some hospitals that treat medically these patients with non-STEMI left main three vessel disease diagnosed at cath 30% of the time. That is way too high, and there's variability because, for the exact reason that Ramesh mentioned, people say avoid these patients and don't necessarily treat them because they're too high risk. Finally, one other study that I'll show you, and this was one of our fellows did this analysis with us, basically looking at patients who present with new onset heart failure. They come into the hospital for heart failure for the first time. How frequently do they actually get tested for ischemic etiologies of the heart failure? Because, as you know, ischemic etiology is the #1 contributor, or the #1 cause of heart failure, at least in the northern hemisphere. And it turns out that within 90 days, less than 30% of patients actually had a test, and that's a nuclear stress test, a stress echo, an MRI, a CT, or a cath, to determine whether they had heart failure of an ischemic etiology. So they just give the patient diuretics, they say you're going to be fine, they say there's no data for revascularization, and then the patient goes on to have further problems. So this underutilization was something that we wanted to address, and that's why we sort of came up with this initiative. So it's funny you asked the question before, because the question is, what is CHIP? And so there's many different acronyms that you can use, and we don't profess to have the perfect acronym, but we initially started with complex, high-risk interventional procedures. We then moved it to complex, high-risk indicated patients, because you needed to have an indication. It wasn't just about the procedure, it's about the patient. And then some people have turned it into complete revascularization of high-risk indicated patients. So no matter what acronym you use, the point is we're looking at high-risk patients that should merit revascularization based upon their symptoms and or their disease, and how can we identify these patients and treat them safely and effectively. And we tried to elucidate this in a white paper that we published in Circulation a couple years ago, and this was a group of a lot of people that contributed to this, but the whole idea was to focus away from low-risk patients who might be managed medically, who might not gain a lot from a procedure, who might actually have a complication from a procedure, and focus on the higher-risk patients who have more to gain. The other aspect of this is that we specifically mentioned in this whole initiative that this is not about PCI. This is about revascularization. If the patient is a good candidate for surgical revascularization, go for surgical revascularization. What this initiative is about is patients who are deemed to basically be candidates for revascularization and then figuring out how best to get that patient revascularized one way or the other. And so we are not anti-surgery at all. Hybrid procedures, pure CABG, they work great in selected patients. This is about revascularization as a whole. So the reason it's about revascularization as a whole is because there are a lot of people out there who say that in stable ischemic heart disease, there's no evidence whatsoever that coronary revascularization improves prognosis. This is the prevailing wisdom that's out there. If you read the papers, you read the New York Times, papers worldwide, they basically say that the reason to treat patients with coronary disease is for their symptoms and their symptoms alone. Well, first, if you talk about symptoms, it's pretty clear that if you focus on patients with severe symptoms, this is data from the FREEDOM trial, same exact results shown from the SYNTAX trial, same exact results shown from the STITCH trial, same exact results shown from a host of trials, their quality of life improves with coronary revascularization, and it's basically similar if you do surgery or PCI. So high-risk patients, lots of symptoms, do better with coronary revascularization. This is just a letter that I got from a patient who had a severe disease, low EF, and a CTO, the LAD. They send you messages like this: I thank you for all of your help. It's a great feeling to be angina-free. Typically speaking, especially in the modern age when people SMS you, it's really nice to get a written letter like this, and these patients really genuinely have improvements in their lives, and they're very thankful to you for it. Now, beyond symptoms though, it's very important to remember that coronary revascularization of high-risk anatomy is associated with improved prognosis, mortality, and otherwise. So this is just a slide from the ACC/AHA guidelines that essentially looks at the extent of coronary disease and what the actuarial 5-year survival is, assuming medical therapy only. So on the right of the slide is the 5-year survival. You can see as the disease gets worse and worse, 5-year survival starts getting around 65% or less. That's a problem, especially if you're a young individual. And so in these types of cases, this is where coronary revascularization shines. We know that this is the case from left main studies. This is the most recent data from STITCH, the STITCH's extension trial, showing that even though there's an upfront mortality risk with coronary artery bypass grafting, if you revascularize these patients over time, you save lives with a number needed to treat of 14. So that concept is imbued in the whole CHIP premise that for high-risk patients, we can improve not only symptoms, but also prognosis. Ramesh showed you this slide. I'm not going to go through it in detail other than to say that we define who these patients are. There are a variety of ways, and it doesn't mean that you're a CHIP patient if you have one of these. The other thing that's important is CHIP is not about a particular device either. It's not just, oh, I used an Impella, therefore it's a CHIP case. There are a whole host of things that go into these types of cases. It's more of a mindset, and hopefully I've set the stage of that for you, and this will hopefully be covered in other talks as well. Really, the other aspect is making sure you're properly trained. So you have to be adequately trained to do these cases. You cannot be an amateur and tackle the highest risk cases without having complications associated with them. We know this for sure in the United States, where only half of operators practically perform fewer than 50 PCIs a year. So as exciting as a CHIP concept may be, if you're doing less than one intervention a week, you're not going to be helping patients. In fact, you're going to be hurting patients if you try to tackle these types of cases. And we'll have a debate a little bit later that talks about dedicated versus non-dedicated operators. At Columbia, we've started a program with CHIP fellows. These are some of our folks, some of whom have actually spoken at meetings here in India. But I do think that the typical mentality of the CHIP fellow is imbued in this next slide here. If you see, this was at our holiday party. Everybody's having a good time. These are the valve fellows in the top right. The endovascular fellows are here. The only one with the eye on the prize is the CHIP fellow in the bottom. He remains focused despite all the calm, and he's one of our fellows currently at Columbia who's finishing. Now, in terms of what you need to know, there's a lot of things. And so we elucidated this in the manuscript. You need to know how to treat all these different lesion subsets. There are a lot of devices, there's a lot of techniques, and it really takes dedicated efforts in order to do it. Dedicated efforts also pay off because there are volume outcomes relationships that can be demonstrated in these higher risk populations. This is data from China. Same center, Fuwai Hospital, the most busy PCI center in the world. At the exact same center, a high volume operator treating a left main has better outcomes than a low volume operator treating a left main, even in the same hospital. So this is important, and it really goes to show that you have to be dedicated in this way. The same thing we've shown in New York State, where the highest volume CTO operators typically have the highest rates of success, and overall success rate in New York State for CTO PCI is only 60%. So if you're only slightly better than the flip of a coin, that's not good enough for your patients, so you need to have dedicated training. There are also more recent studies showing that with the use of imaging, physiology, and also CTO techniques, newest generation stents, we can improve upon predicate prior outcomes, therefore potentially matching surgery, although not shown in a randomized fashion, but at least we get better and closer to it, because let's face it, surgery is the gold standard. And if we want to come close to it, we need to do everything we can in order to match it. So just a few final thoughts. The fundamental of the CHIP mindset is that the clinical indications for the case don't change just because the lesions are harder to treat. If somebody is very symptomatic and you think they need revascularization, and then you look at the angiogram and it looks scary, the patient's symptoms don't go away. You're offering them medical therapy because you can't treat the angiogram. The reality is that you need to either learn how to treat it or refer the patient to somebody who can. One thing that's very important is not to just embark on treating something that you don't know how to do, because you're going to cause more harm in that situation. This is very well illustrated in the Syntax trial. This is a nice slide from the trial I like to show, that at each individual site is a dot or a bubble on the graph, and the size of the bubble is based on how many patients they randomized in the trial. This white dot on the right side is a site that had a MACE rate in the cabbage arm that was 40% and PCI only 10%. The red dot on the top left here is a site that had no MACE in the cabbage arm and a 50% rate of MACE in the PCI arm. If you're a patient and you're at this site, what do you want? Do you want CHIP PCI or do you want cabbage? Similarly, if you're at this site, what do you want? Do you want cabbage or do you want CHIP PCI? The bottom line is, unless we're humble and know our own limitations and strengths, if we just try to indiscriminately apply what I'm saying to all of our patients, we're going to cause problems. And so you have to be very, very circumspect about it and then offer the patients the best options. We have a number of courses, as many of you are familiar with, that we try to teach some of these concepts. Additionally, we've outlined a number of research priorities, because this is not just a concept that makes sense and we just want to go with it. We actually need to show that these things can actually work. And I'm not going to go through these in detail other than to say that we illustrated them in this manuscript. There are a number of trials that come out and studies that come out that are very informative. This is a study from our former fellow looking at collateral channels and CTOs, what's safe, what's not safe, what are the most common things. Similarly, trials like the Excel trial, Ultimate CHIP trial, surgery versus PCI for left main disease. Left main disease is a CHIP type of patient subset. We're running the Eclipse trial. This is a trial of atherectomy versus conventional angioplasty for patients with severe calcified coronary arteries. Ashish mentioned the Optimum trial yesterday. This is a study looking at quality of life among these patients that are surgical turndowns to see how they feel. And then there are other studies in the UK. They're doing a trial called Revive, which is basically ischemic cardiomyopathy. It's like Stitch, but with PCI. Ischemic cardiomyopathy, medical therapy alone versus PCI plus medical therapy. So just to conclude, the basic CHIP premise is that there is a large underserved patient population that can benefit from coronary revascularization, rather than focusing on low-risk patients who could be easier to treat. It's very easy to treat a type A lesion, but is that patient really helped relative to some of the other disease that we've seen here at this meeting? Those have more to gain. We're going to see more and more of these patients as the healthcare system evolves, and we have to develop ourselves comprehensively with not only advanced technical skills, but also cognitive skills to be able to understand these patients and to treat them effectively, and that's what's sorely needed. So we've had a good start, as this is the Freedom Tower being put up, but there's definitely still more room to go. Thanks so much.
So actually, I think in most of the CHIP session is going to be more or less repetition, trying to remind the need and trying to tell as to how to develop the skills. So for any program, I think you first need an operator. What I was supposed to talk about as to how to build a team, but I think for a team you have to have an operator. And most of us feel we are like this. In fact, we may be like pussycats. And we might be slipping often while trying to do slip cases, which is a new term which I am trying to do. This is a simple, low risk. This is a simple patient and low risk. If you look at the LV is fine and no comorbidities. So many of us slip while doing these kind of slip cases. So we have to convert, and if we really get a CHIP patient, this is what we do. We just don't want to handle, we want to run away from this patient. So if you want to convert a pussycat to a lion, I think you need some kind of methodology. See, according to me, there are two routes. One route is which is not available in India. I think Impella is going to be shortly available. But to work in the protected environment, you want to learn hunting, so be in a cage, go in a jungle, and you start hunting. So that's how it's an easy prey. So I call it a ship. Ship means the case is simple. If you look at it, this PCI is simple, but it's high risk. And why it's high risk is, if you look at the add-on, the low ejection fraction, low blood pressure, faster pulse rate, high PA pressures, and low PA saturations. So just in case you get into trouble, it will be very, very difficult. So the best situation is that you go in a protected environment, you get a protection, and once you have protection, then you can finish the PCI. And these patients, they improve, as in shown this, that the ejection fraction climbed, and even the clinical status also improved. So this is one way. I don't think we have the luxury of treating or training ourselves in this way, because we cannot start and pick up simpler cases because we don't have the protection at the moment. And even if the Impella is coming to us, I don't think it will be available to masses. It will be available to maybe less than 0.001. So we have to take the other route. And the other route is when you do not have the facilities for a protected environment in the form of circulatory support. So we will have to start with CLIP. By CLIP, what I mean is you gradually train yourself, so you start doing difficult cases. And C as a part of CHIP, I think most of the time the complexity is in the form of CTO. And second complexity is in the form of calcified lesions. So we have to gradually train ourselves so that we take on complex patients, simpler CTOs and difficult CTOs, antegrade, retrograde, and hybrid, and also calcified, and try and use different hardwares, develop skills so that you can take on these patients and avoid complication, and just in case you get into a complication, you should be able to treat them. So that you take these complex patients, initially low risk patients. It means you start your practice in patients who are good left ventricle, good hemodynamics, PAs good, and then be proficient so that you're able to handle these complex cases and get good results. And gradually you can develop your skills so that you can start these complex cases in not a very good environment, in low ejection fractions and compromised hemodynamics. Like this patient, which I treated last month. If you look at the LV, of course, I didn't have the luxury to have the protection, and that was the anatomy. Not a very good. LED is getting retrofilled, and if you look at the RCA, it's also having too many points to tell you, too many degrees to tell you that I'm not very easily done. That's what was the left, and in case, if you have a close look at the left, that's the LED, and this large one is diagonal. It's not LED, it's diagonal. That's a septal, and you don't know where is LED. And we were able to put a couple of stents and get a decent result. And of course, I didn't have the luxury to support the circulation, so I will divide it. I will handle the LED first, and I'll call this patient after some time to handle RCA. So what I feel is, those who are doing SLIP, if they have the facility for circulatory support, they should start shipping. And ultimately they also start doing complex cases so that ultimately they can do CHIP. And those who do not have the luxury of support, they should start clipping. And then finally you can go to CHIP. But what is important is those who are doing CHIP and not doing complex cases, they should gradually train themselves. And those who are doing clips also should start getting a training as to how to get the circulatory support and also handling the wide boards at the groin. So once you have developed all these skills and now you are a chip operator, you are good both in front and behind the wicket. Let me tell you, even for the king of the jungle, it's a team effort to bring down the buffalo. You alone probably cannot do anything. And if you have a team, all 11 Dhonis, I think it is an imperfect team. You have to have a team which is like this. Different persons, different positions, everybody should be the expert and a champion at his position, and they should be working with each other in a different fashion, I'll just tell you. So if you have a structural heart or a heart failure or a CTO program, I think it is much easier for you to start a CHIP program. So you have to have anesthetists, people who are doing critical care, cardiac intensive managements. You have to fit these experts with cardiovascular surgeon, the vascular surgeon, the structural heart and heart failure and EP team. and imaging experts, the echocardiographer and the intravascular imaging. And you have to have clinicians also with you, because if you're doing alone and the clinician not backing you up, I think your program can go flop. You have to have dedicated nurses and technicians with you, and most importantly, patient and family on which you have to spend a lot of time. Well, your program cannot be successful unless you are backed up by the administrators. You are at the center. Well, let me tell you, you have to take all the responsibilities, and you are answerable to all kinds of litigation, which, let me tell you, you are in an environment where you're likely to face many of them. Well, many of your teams, you will have a team structure where you'll be sitting on the top and bossing around. I don't think this is going to work, because the colleagues from whom you're going to have a kind of help, cardiac surgeon, I don't think you can boss around with him. You will have to be friendly with him. You have to get at level with him in a sort of jigsaw puzzle, take the help from them, being at the same level, being still more responsible. It's a totally difficult scenario in a very unique environment. And since he has to work with a clinician who's very, very important part of the team, and as Ajay mentioned, the creeds are different of a clinician and the operator, totally diagonally opposite. As Ajay mentioned, that if the things are hard, means you should not just say that if it's hard to treat, go on medical. You'll have to be harder to handle these. And which often, once you acquire the skill, you try to handle them. But there is a clinician who says that just because you can treat, you should not be treating. So you have to strike a balance between being very aggressive and being conservative. This is how only you can keep the clinician with you. If you don't strike a balance, I think your clinician is going to make your program unsuccessful. Now, in the beginning, I think you will have to have cases with very, very strong indications. If you're taking patient with not a very strong indication, and just in case you get into trouble, I think the program will be not successful. Consent has to be totally different in CHIP patients. It has to be very, very well-informed consent. And I say that if you can, I think you should go for an audiovisual recording also. Properly briefing about everything, including complications, tamponade, perforation, and radiation injury, and so on. You should clearly advise about mortality and what is going to happen to the LV function. I think, and document everything, because this is an environment, just in case you get into a litigatory process, this kind of a thing is going to help you. And whenever you are handling such cases, in case things are not going your way, if you are thinking about a litigation coming in front of you, well, your skill will go away. You'll just get into mess. So you have to ensure that your team is nested. So you have got a training. You go and attend CTO workshop and hemodynamic workshops. You have to have nurses and residents and technicians who are also very well versed with it. You have to send them to these places so that they can be familiar with these. And well, however good you are, you're still going to get problems. If you get into troubles, I think you have to be very, very strong mentally. And if you have some kind of a program going on, like you have a LVAD or a CTO program, then you should be looking for a heart failure program and vice versa. So you have to have almost everything. Now, how to get cases? Well, physician will typically send the patient to the interventionist, who will send the patient to the surgeon, and the surgeons are usually not excited to handle these patients. They will send the patient back to the interventionist and back to the physician. So where is a CHIP operator? Not in the loop. Not at all in the loop. Well, surgeons will never send a patient to you. But what I am doing is, I have a fellow who's doing work on it. We are working on something like an optimum trial, and the work is going on for the last 2 years. We've done about 80 cases, more or less what is the Grantham's trial. So the fellow will take up the cases which we think are CHIP patients, and we're pretty sure that the surgeon is going to deny them. The patient is sent to the surgeon. Surgeon will have a look at it, and surgeon will say, sorry, we can't do it. And once the patient is brought back, we handle the patient, then all feedback is given to the surgeon. Surgeon will gradually develop a confidence that, look, this patient was rejected, and now this patient has been done, and it's doing well. That's how he'll start sending patients to you, which were referred to him by other interventionists. So we send our fellow with a patient like this, and many of them who are like this, often the surgeon will turn down. Then your friend will almost never send a patient to you. Interventionist, I think even in the same center, it's not very easy thing to have referrals from your colleagues. But still, I think you can send an invitation to him, and some of them will come back and will try and see as to what is going on. And if he finds that you're doing a good job and you're not making a lot of money, you're taking a lot of radiation, I think he will not mind sending cases to you. But I think physician is very important. You have to garland the physician, because he becomes the chief to send patients to you, I think you should not lose a contact with the non-interventional cardiologist, because they can be very, very important feeders to you. Heart failure specialists, after they have treated their patient with medicines, and now still a lot of them will be symptomatic. And also electrophysiologists, after they have given some devices like ICDs and CRTDs, many of them will be symptomatic, and ICDs will be getting recurrent shocks, or somebody getting into, say, VT storms. Having ischemic basis, I think you get in touch with them, and they can be your regular feeder. But let me tell you, this is a very serious business. It is not for anyone and everyone. And for it to be really successful, I think you need a hub and spoke model to be really proficient and cost effective, so that smaller centers are linking with the intermediate center, and then big centers. There are different strategies, but with Modi Care coming, with PCI instant for 40,000 and MI management for 10,000, I think good luck to all these management people. Thank you very much.
So that was a great talk. I'm not sure why you said it was repetition. This is perfect.
My name is Ashish Prashad. I practice at Baylor University in Phoenix, and so I'm going to take the stance of there's no need for a dedicated chip operator. Of course, I have a bunch of disclosures. Firstly, I am a chip operator. Number two, I'm taking one of Ajay's fellows who's going to be coming and doing a chip fellowship with me starting this year, along with some structural training. So I'm very much engaged in the process. However, my stance is a little contrarian for the purposes of this meeting. And so I'll try to take a couple of questions and keep my slides limited, because there's going to be, of course, a ton of slide overlap. So what's the algorithm? The problem is, because we've sort of had this apathy towards treating CAD for multiple reasons, and a lot of the times people just end up getting treated with optimal medical therapy, and then put on several drugs with optimal medical therapy, and then the revascularization consideration is considered all the way down at the bottom. And most of the time, by the time the patients get to us, they've already been miserable for a long time on multiple drugs and not quite feeling well. So obviously this was the impetus. Ajay talked a little bit about this being Jeff's vision, but I think he's being humble. He was very much involved in the process. And the birth of CHIP really was predicated on these four things. One, the PCI volumes in the US were precipitously declining, with generally internists, New York Times reporting, lay press, heart failure specialists, internists, all looking at PCI in a very suspicious way and sort of not referring cases even when appropriate. The general apathy and doubt was not just based on, I think, jealousy, but the fact that they honestly believed that PCI and stable ischemic coronary disease in the background of trials like Courage, this was even before Orbita, was not essentially helpful, and hence they weren't being sent. However, what it did allow us to do is start thinking creatively. And what we did realize is that there were a large group of patients that were completely appropriate for treatment that were just not being identified. And that really led to this whole undertreatment bias that has been very elegantly demonstrated by Ajay in some of the slides earlier. The last piece was that, the educational value for the interventional training programs in all our ACGME accredited programs had greatly diminished, because most of the major academic medical centers had declining PCI volumes. And so we were training fellows that were supposed to be coming out of training to be well-versed in some of the things we thought we would get them well-versed in, but they were just not getting the touches that they would need to get the expertise. I'm talking about things like atherectomy, things like image interpretations, things like complex PCI, things like bifurcation management, and I'm not even talking about things like CTOs. So that led to this definition of the population. We've heard about this. I won't waste too much time. But the bottom line again here is that patients were severely undertreated. This led to this white paper that Ajay spearheaded. And since this white paper, we've met, I think, before TCT last year, and we've sort of done some further deep dive into creating subgroups of us that are going to be looking at different aspects of this whole CHIP premise. And so there's a lot of work that still needs to be done. But this is a paper that I think warrants reading for anybody that wants to become an expert in the field. So I also want to, with the backdrop, focus on what I believe has been a complete abject failure of our training programs in interventional cardiology. And so when you look at the goals of what our training programs in interventional cardiology, I want you to focus on several things. The first thing is goal number 2, to achieve appropriate cognitive knowledge and technical skills necessary to perform interventional cardiac procedures through the present state of the art at the level of the quality attainable currently. Number 3 was to foster an attitude of lifelong learning and critical thinking skills, and to gain from the experience and incorporate new developments. And the last thing is commit to quality assessment and improvement in procedure performance. And I can say worldwide, we've done a dismal job. How many of us have gone back and looked at our training and do things exactly the way we did when we were trained in our fellowships? And by that I mean over-the-wire balloons. Traditional wires that we used 20 years ago are the same wires we use today. How many of us have even left our cath labs and gone to other labs to update our skill sets? How many of us have looked ourselves critically and said, what new skills have I acquired in the last 6 months since I took and did my last PCI or attended the last meeting? We all come to meetings, we hear about different things that are done at major centers, get enthused, get excited, but once we get back into our daily grind, none of us are able to incorporate what we've learned in a meaningful way to impact our patients and care. And I think that is a fundamental flaw of where we are today. And that is why it has come to the point where we need to start looking to dedicated chip operators to train from outside in, because we've done a very poor job to train people from inside out. So look at the training skills and infrastructural requirements that Ajay elucidated beautifully in his white paper. And then on the right side, we have 41 ACGME accredited training programs in the United States. I think Ajay is a program director of his interventional program, Ramesh is a program director of his interventional program, I'm a program director of my interventional programs, and we have simply not been able to do a good job to be able to train our fellows to acquire all the skills that we need. So there are 319 fellows that are pumped into the healthcare system for employment annually. Most programs are a 12-month dedicated fellowship, but yet I don't think at the completion of their 12-month fellowship, they're able to do the things that we need. And this is part of the ACGME ABIM certification requirements that's listed in the training. They're supposed to have the appropriate skills to image with flow wires, ultrasound, OCT. They're required to have all the skills to treat complications, both in lab and post-procedure. They're required to be able to treat hemodynamic instability, including the emergent use of mechanical circulatory support, and be able to perform pericardial tamponade. They're required to learn all possible atherectomy devices and basically be able to treat complicated lesions, including bifurcations and multivessel disease. This is a requirement that is expected when somebody comes out of a training program. I can tell you that out of the 319 fellows that graduate from training programs in the United States, less than a quarter have all the skills. In fact, I would make a case that there are some interventional fellows graduating from training programs currently that finish their whole year without ever having done a pericardiocentesis emergently. So I think it's one of the down products of us having gotten so good at bread and butter PCI and risk averseness to take on complex cases that is now hurting the next generation of who we're going to train. Quick mention about our institutional volumes in PCI. As we can all see, this is unpublished data from, actually has been published since this is an old slide, that looks at, the outcomes with lower volume operators, as Ajay demonstrated, not just in the US, but even outside the US at major medical centers like Fuwai, also clearly showing that the higher volume operators have better outcomes. And here are we with our scatter plot of operator volume and PCI volumes, clearly demonstrating that there's a cutoff. And as it turns out, our societies are going the wrong way in minimum competency requirements. We were 75 a few years ago, now we're 50. There's a talk of even becoming less than that in the next few years. So as you can see, the lesser number of cases you do, the less likely you are that you're going to have the outcomes that our patients deserve. So fixing our training programs. I would say the birth of a dedicated chip operator was the failure of our current training programs. What we really need is resurrection and accountability. And the problem is, it's a lot harder to institutionally change that, and hence the birth of a chip operator is mandated because it's a lot easier for us to take control at the centers that work and do the work that we know is of high quality, and hence Jeff, Ajay, and centers like his, centers like mine across the country have decided that it's a lot easier for us to tackle the problem from the inside out rather than from the outside in. I've proposed possible reduction in the number of fellows graduating because I don't believe that the US market can accommodate 319 graduating interventional fellows, especially if they all cluster in urban areas. The ACC stance of decreasing the annual operator volume to maintain competency has not helped the cause. And then I think we still need to figure out a way of having a meaningful maintenance of certification because its current form is just not useful to upgrading skills. The CHIP initiative in and of itself is fabulous because it's led to so many other incredible ideas, like research opportunities that have come up, because we really have done a poor job in understanding the patient population and really have done a poor job in getting outcomes. So far, outcomes have all been device-related rather than disease-specific. And I think the CHIP initiative allows us to really look at this in a very, very different way. And I think that is amazing. Another byproduct of the CHIP has been programs like the Cardiogenic Shock Initiative. This was initially pioneered by Bill O'Neill, but I think what it is it's really allowed us to know what concepts like cardiac power output are, pulmonary pulsatility index are, the need for a right heart, the importance of the PA-SAT, the importance of assessing wedge pressures. All of these things have been byproducts of the CHIP initiative, and I think we're very grateful for an initiative like this because it has made a huge dent in enhancing the competencies and the quality of PCI that we've done. And last but not the least, I think in conclusion, I think we need CHIP programs, not dedicated CHIP operators. Hence, I make my case.
Basically, we are from India. There is a lot of inadequacy in our country. We can actually train an operator to get the results coming out. That is the only possibility, as Dr. Trahan mentioned. I'm actually telling about some of the situations which I came across. It is actually a patient of CABG done in 2008 with a creatinine of 1.8. Angiogram done in 2016. I showed all the patent grafts with SVG2OM occluded and osteoproximal circumflex totally occluded. Patient was avoided stenting to circumflex but took a second opinion and advised not to do it because of the permanent dialysis. And patient never came for an angioplasty. Now the patient has class 3 angina on 4 anti-anginal drugs. See, this was an angiogram done in 2015, advised not to do an angioplasty because the patient has creatinine of 1.8 post-CABG. Now, this is the situation. The patient has a totally occluded circumflex. We tried with a balloon. Actually, we never knew where is a distal vessel which is not seen. I tried with a tonus and failed to pass. And I just passed the balloon, actually tried, failed, and tonus tried to pass. Tonus could not go down. And I used a rotablator, 1.25. Actually, by seeing the old angiogram, I passed the wire down, 1.25 rota. Then rota just touched the proximal part, nothing, it never gone down. Then I took a 1.5 millimeter balloon. Finally, the patient came out. This is the first case, and actually this is a second case. Patient with an MI, inferior MI, recurrent unstable angina with cardiac failure for 3 months, class 3 symptoms, has a history of TIA, severe LV dysfunction, diabetes, CKD stage 3. Patient has LMCA with 3 vessel disease, RCA CTO, RCA territory is non-viable. When they did an evaluation of the carotid artery, right internal carotid artery is totally occluded. Left internal carotid artery is 90% disease. Surgeon not willing for CABG and advised better to die due to an MI rather than due to a CVA. Our plan was the patient came to me with a 24% EF with a carotid artery included. This was the angiogram. We tried to open the vessel. Stented LMCA to LAD. Then I recrossed the wire and distal LAD also stented. Kissing. 2 stents and finished the procedure. Then after 6 weeks, we did a carotid artery intervention. Doing very well. Patient is now symptomatically better and functional class improved from class 4 to class 1 and LVEF improved from 25 to 40%. This is third patient, LVEF, from 2016 evaluated in a major hospital, all investigation done, including cardiac MRI, and reported as a partially viable myocardium. LVEF is 24%. Told that PTC and CABG are not suitable option, only option is a transplant. Patients and relative not ready to die with somebody else's heart. Came for second opinion. This was angiogram. Crossed. Partially viable myocardium reported. I put 2 stents. RCA opened up. Circ totally occluded. Again opened up. LAD stented. This was the final result. And now situation of the patient today is completed 2 years and 3 months as on today. LVEF improved to 40%. No admission so far after that. And doing business and driving his own car and coming and seeing me from 250 kilometers from my hospital. There's another patient underwent cabbage for TVD 8 years back, angina for 2 years. Then the program actually, angiogram shunt, TVD with occluded LMCA and only LMCA to LAD patent and other graft occluded. We did a PTCA to circumflex, total occluded, opened up the circumflex with 2 stents and RCA is opened exactly after 3 months when the graft opened up. This was the final result. We used this many materials, which is not possible in our country. It is actually done with an IGCT program. The patient had a clinical examination of this, actually case 5 with a dyspnea on class expiration, actually COPD on inhalers for the last 10 years. And patient has a global LV dysfunction and 30% EF, occluded LAD from ostium and LMCA critical disease from ostium and RCA normally filling. But the SpO2 is actually 80% on room air, and postoperative recovery will be very difficult and distal vessels are non-graftable. This is a patient, totally occluded, and we did a retrograde CT intervention and finished the procedure. This one is actually a 67-year-old politician, class 2 dyspnea. Creatinine is 1.8 to 2.4, the various report, global LV dysfunction, and EF of 22% with a mild to moderate MR. LMCA, distal LMCA 20 to 30%, osteoproximal 90% circumflex, and RCA normal and PDA is occluded from the mid part, and both PD and PLV are diffusely diseased. Advice, only medical management, approach various hospital and various cardiologists. The accidental approach to our hospital lead on to see to me. This was the angiogram. Distal LAD is totally deceased. Circumflex is totally occluded distally. This patient came to me. What I did is actually I told them that we will be having a high risk procedure. We opened up the distal circumflex only, and I told that if you improve, I can try for the other one. Balloon dilator, stent, LMC also I stented, LMC and distal circ. This was the final result. And after 3 months, the cardiac function improved to 45%, and the patient wants to do other blocks and decided to do LAD. I passed the wire. There was a real difficulty of taking the catheter down. Then stent was not able to take distal LAD. We decided to take a guideline up to the ostium of the LAD, and they taken the stent down, and the next stent is also taken down through the guideliner. So 2 stents taken 40 and 35 together and produced result like this. And after 1 year, 1 year finished now, no admissions after that. He himself claiming that 3 months life allotted by doctors is postponed for more than 1 year. Advising many patients to come to my hospital and how he come for LMCA bodylation. This was a 93-year-old man, now 99 years. Echo normal study, patient admitted for a TKR with anemia. The first postoperative day, patient developed severe chest pain, troponin was positive, anemia corrected with PRP. D2 onwards, recurrent ST depression and flash pulmonary edema, constantly getting abdominal pain, recurrent LVF. Patient had a circumflex totally occluded. RC was actually having disease. There is a disease in the LMCA, calcified or thrombus, which we don't know, very tortuous anatomy. 92-year-old man with 122 children, 8 doctors in the family, luckily no cardiologist in the group. Anatomy was confusing, femoral approach is not possible. 4 cardiologists approached, not all opined for not to do angioplasty, but given a positive response. No positive response even for the cabbage. Cardiac surgeon in mid-Kerala approached, radial approached. We finally did the angioplasty, and patient is still surviving after 6 years. All the above cases are not done by the presence of support systems. Attitude of the operator and the confidence of the patient only matters. If operator is not confident about their skills, these cases could not be done. Better equipped cath lab with all support system is contributory. Training program is absolutely needed, but the support staff like intensivists, anesthetists, cardiologists may help. But finally, in India, in the setting of our country, the operator and the operator and the operator only decides the fate of G program. Thank you.
On the balloon pump, the observation that we've had, at least in the United States, is that left main is a good example. Right now, in the Excel trial, the use of hemodynamic support was less than 5% of cases. We pretty much routinely, for left main disease, unless the EF is really low, will not use hemodynamic support with either a balloon pump or Impella. But if you go around in the United States, there's so few people doing left main that the prevailing wisdom among those operators is that you can't do a left main without putting an Impella device in. One of the things that I've noticed is that sometimes, I could go around and tell them you don't need to put an Impella device in, but actually I think in some of those hospitals where they're not used to doing it, I actually don't have a problem with them doing it because it'll give them a backup of safety, because they're just not used to doing these cases quickly, effectively, disengaging the guide and doing it in ways that you do or any of the rest of us may do it. So I think also the indications for the support device and even the adjunctive technologies are dependent upon the operator's confidence and the team that they have at their hospital more than just the patient and the anatomy as well.
And I think that's a reflection of what the FDA looked at, and hence their indication got expanded for exactly that.
Probably, Ajay, actually, if you get a lot of negative or effect by your procedures, probably I will be switching on my practice. So far, luckily, everything is going in a smooth way. That may be another reason.
No, actually, for crash situation, I don't think balloon pump really does anything. If you get into crash, I think it may not be a very effective device. But at the same time, if you're handling patients who have some compromised LVs and the hemodynamics are compromised, I think it's a good practice to take them on a pump pre-hand and let them be stabilized, and then, because it does definitely improve coronary perfusion, even if it is not adding too much to the cardiac output. So I don't think it's a device which is totally useless. But for crash situation, I don't think it is. And as far as protection is concerned, all of us have been doing cases without Impella. But the kind of adrenergic surges which we have, I don't think somebody who's maybe. I remember my PCIs, which we used to do 1990. We used to do it on partial cardiopulmonary support, which was described by Fayaz Shaw. There was nothing but a CPS. We used to use 18 French system, and we used to take the patient on support, which is like an ECMO. And sometimes the patient will fibrillate, and some support staff will be ready with the defibrillators to shock the patient. The patient is saying, no, I'm all right. And the circulation is supported. So environment used to be relatively protected. So there is no doubt that if you can support the circulation and you are doing difficult cases, then your adrenergic surges are less, and now you also given enough time to complete revasculations. And one of the downside of doing a complete revasculation is that you're adding problems. But if you have a protected environment, it can permit you to do more and more reasonably. Means you don't leave.
Definitely, it may give a value to you. But if at all it is done, it is to be done procedure.
But I don't think the amount of the cost which is going to be there with Impella, I don't think it will be available to most of the patients.
I think
sir,
we need to strike a balance actually. I'm sure that we all understand physiology, but there is so much of myocardial reserve. Despite you see a 24 EF, if there is a viable myocardium, there's so much of reserve that you can go through the procedure without any support device, in fact. And we do these complex cases day in and day out, and without any support. Maybe sometime we use some inotropes, that's all. And this is not difficult because myocardial reserve itself takes it over like a, protection.
Yeah, the kind
So-
of
But I agree with the left main situation. If you have a distal left main and severely calcified lesion, you are going to do rota there, and EF is low. Surely you should have preempt with the support device and then do it.
Yeah,
That's what.
as far as myocardial reserve is concerned, in my practice, I use tons of intracoronary epinephrine. Tons of it. One of my
Absolutely.
fellows there.
Absolutely.
Tons of it. That means
Tons of it.
that
Tons of it.
Tons of it. That means I take an ampule of intracoronary adrenaline, dilute it in 50 ml of saline, and we just push it into the coronary.
we push
artery.
it.
That gives you time, and whatever myocardium which we think is hibernating, that gets into action for a while.
Absolutely.
Of course, these are not the methodology which you can do if you have to do a complex case which is going to be extended, because these kind of things can be supported only for a short time. And
Sir,
but
sir,
if you have to do a long procedure, I don't think we can do it.
Sir, I think the debate which has been started has rightly been said. There is a chip operator who is saying I can do it, and there is a non-chip operator who is saying I need all the Impella and things like this together. So we have to find out a balance somewhere between, because a chip operator can do it doesn't mean that I can also do it, or somebody else can also do it. So we have to find out a balance that where the support is required and where the skills are. Skills cannot be enormous to that of Dr. Vijay Tirhan or Dr. Pratap for everybody, but they have to operate upon chip patients also. So they have to balance somewhere. What I wanted to say that, so you have started this in Colombia, and we have all taken it up and we are doing studying it together. You have to find out a way how a chip can be converted into a ship, how it can be made simple. And you have to devise a thing that everywhere we can't use all those armamentarium which you are supposed to see and use them together. So we have to say somehow the methodology or algorithm has to be taken out, how a chip patient can be converted into a ship patient or maybe a slip patient. Sir rightly has given new terms. So this methodology will give us a ordinary, a reasonably acquired skilled man to do these procedures. Because everybody cannot have a skill of Dr. Pratap or Dr. Vijay Tirhan or maybe Dr. Kirtane. We have to devise a system, and that goes responsibility on the people who have started the program.
Yeah, I mean, one of the things that I actually think with a lot of these adjunctive devices, not just, support, but atherectomy, they do, if you know how to do them, make the cases easier. I know that, intercoronary epinephrine sounds like it works and it's great and everything. I will tell you that for any of you, if you're a very good operator and you use one of these devices, you will see that your own adrenaline surges go away. It's just more relaxing. On Monday, I have 2 cases, both low EFs, 35. One I have to laser the left main, the other is a multi-vessel PCI involving the occluded right. And like before we had this, I would be thinking all weekend about what could happen and how is it going to happen and how is it. I'm not even worried about it because you know that you can support the patient through the case. So those types of things are helped not just by Impella or support, but also atherectomy will do it. In some cases, by the way, physiology and imaging too. Sometimes the physiology shows you that you don't have to put in 18 stents, you can instead put in 6 stents. So that aspect can be useful as well.
And it's not a reflection of bravado. Or, I mean, cost I completely get, and I completely am respectful of that. Having been born and raised here, I completely get it. But I feel like the business of chip operator equals bravado, or a chip operator equals I am better than you, is a wrong mindset.
Yeah, that's
I
not
don't
it.
think we need to. I think that is not a kind of.
I quite agree with you. 100%.
That's not the way we want to try.
I 100% agree with you.
We don't want to tell the chip operator is better than another operator, right? We are telling that the attitude of the operator should be there, and the attitude should be there, we can do the procedures. Basically, some of the times, the people are not interested to do the cases because we don't want to take attention of the patients, and having a mortality of 25% or 30% and facing the relatives and the patient, it's a real challenge. Number one, non-availability of Imbella like supporting system, non-availability of a cardiac anesthetist inside the cath lab. These are all our problems we
These
face.
are the practicalities. In fact, see, if you're living in utopic conditions, I think anyone and everyone should have a circulatory support, because even slips can get into trouble. But let me tell you, they are invasive. They cut your pocket, they cut your groin, and the present day systems, if you're a friend, they do both. So I think we have to selectively choose cases. Like you very rightly said, that somebody has an EF of 25%, his heart rate is 110 or so, his PA saturation which you took is something along like 55, 60. I think this is not a case where you should just believe that I'll give adrenaline and intracoronary epinephrine and I'll do the case. I think this is a case which pre-hand, if in case you have a circulatory support, you should do it, or else send this patient to a place where these cases can be done, or maybe persuade your surgeons. But at the same time, somebody whose LV is not very bad, his heart rate is 70, his PSATs are good, and he has a bad looking left main, you should have, if you have experience of handling those left mains using atherectomies and all, I think if you have a plan with you, not straight off means putting a stent, but not straight off going with a 20 atmosphere or 24 atmosphere, which will lead you into a slow flow. Maybe deploy a stent at 6 and 8, give some breathing time, give some vasodilators, so that now you can, if you go with serially going at high pressure, the coronaries are able to adjust. I think these are small little things which can help you, and many of those cases which are rejected by surgeons, by now we have more than 80 such cases in the last 2 years. We have a fellow with us, which we are analyzing. Those were surgical rejects and bad things, but reasonably very good results, and both clinical results as well as objective evidence of improvement in left ventricle functions.
Now, the quick question, do you actually videotape your consent?
No, but we have started some of them.
Really?
Now, yeah, because I think this, if you do a videotaping of the consent and take almost, explain everything, it's a, once you are doing a procedure, just in case something wrong happens, if you have videotaped everything, it gives you, because then this is a time when you are supposed to perform the best. And if you're supposed to perform the best, and at the back of your mind is some litigation or some of your friends instigating it, so I think it gives you at least some kind of protection.
I take the consent of the patient and the relative by written, in their own handwritten, that 25 to 50% mortality on table. And that will be written by their own handwritten, because otherwise they will be creating problem. I work in a private hospital, he work in a government hospital. Government hospital is little safer than the private.
No, I'll give you an example.
No. Both hospitals are
both
hospitals are legally equal.
I knew that was going to happen.
Let me just give you. Last week we were doing a TAVR, and this is an Indian TAVR, 22 French system. See, 14 French TAVR is, I think, kids play, but 22 French is not a kids play. And we did a balloon dilatation. The annulus was 20 millimeters only, and I think immediately after we did the balloon dilatation, we did an under dilatation with a 16 millimeter balloon of a 20 millimeter annulus. We start noticing that there is some respiratory variation in the systolic pressure, and because we had been doing a lot of mitrals, so we were quickly looking at the cardiac borders, and I found that the cardiac borders are a little, they're not stationary, but they are not that brisk. So we were alerted that possibly something wrong has happened, and we sensed that most likely a temporary pacing wire, we don't have balloon flotation leads, has probably gone outside. And in fact, there was a lot of struggle finding out a right place to do a good pacing. So I think those dirty wires which we are working in government hospital, we have to take the wires which are the lowest price, even if the quality is not very good. So probably it did some mischief at maybe 5-6 places in the right ventricle, and we had multiple holes. But we had been handling mitrals like this, so we were able to quickly get into the pericardium. But once we are getting into pericardium and draining, there is always at the back of your mind, what is the video consent? We had taken the video consent and everything explained to the patient. This 76-year-old gentleman who had has a COPD, his kidneys are not very good. Everything was videotaped. So at the back of your mind, you always have something which because this is a time like somebody she was saying that pericardial aspirations. And look at the fluid around. Initially, when everything was happening, I asked my resident to show, is there a fluid? He says, no, there's no fluid. I just tell him, because he's not very experienced in looking at a fluid. Then I tell him, look from the epigastrium. He says that possibly there is some fluid, and then the pressures now start going down. The respiratory variations, they become more clear, and now it's 3 or 4 millimeters. Now 3 or 4 millimeters, it's not very easy to tap, especially when you are doing a case like this. And but since we have a lot of experience, we don't let it go to 10 millimeters and tap. We were able to go, like people, when they're putting a Lariat device, they're doing a dry pericardial tap. So we were able to get into that, we tapped it, and ultimately we did TAVR. But what I'm trying to tell you is that if you have a well-informed, well-documented consent, I think you don't tend to fumble while you get into trouble. I think it's not a bad practice to, you should be able to take time out and spend time on these patients, their families, and inform them, document them, and if possible, do a videotaping of the consent.
Wow, I thought New York was bad. It's more litigious here than in the United States. We don't typically do that in the States.
Yeah,
So,
I think, you know, I just want to say 2 or 3 things as the only surgeon here. One is, if you learn from surgeons something, you know, we used to do cardiac surgery, thoracic surgery, vascular surgery, and as we, you know, things got more complex, we just basically just dedicate ourselves to, in my practice, I do mostly valves and mitrals, and we have someone who does the LVADs, and I think the same thing is happening to you guys. As you start getting more complex, I don't care who you are, you need a volume to maintain the skills of this that is so complex. And when you do a lot of this, like the people speaking here, you can decide whether you need an impella or you need a balloon or you need something because of the experience. But when you're doing 10 of these things a year, these people can't do it well. And I think that the message should not be this anyone can do and we can do it without anything. It's one of those things that you, unfortunately, if you want to do this kind of level work, you have to train yourself, you have to have all the options. And yes, every country is different of what you have access, and you have to work within the constraints. But if you have everything available to you, you would use the impella. You know, if cost would not be an option, a problem, then you would do it. As far as this informed consent with video, we have patients videotaping us now. When I'm talking to a family, they get the phone, they start. Our lawyers, they hate it.
Yeah.
Because you're gonna forget something. You're in the middle of something and you tell them 40 complications and they have the 41st complication that you didn't mention,
Right.
that they're deaf because they got too much Lasix, and now all of a sudden is videotape and you didn't say that. So our lawyers have said, do not videotape, do not let them videotape it. You kind of say, the risk to the patient is either 0, it doesn't happen, or 100% it happens. And I think that you can never control for that. So I actually would like to see one of those video things, because I would like to find the perfect one, because then we should just videotape it once
And show
just
it
give
the
it to
same
them.
thing to everybody,
Same
yeah.
video, 150, you know, every single time. And unfortunately, we haven't been able to find that. So I'm kind of perplexed by, you know, by that, which is, I mean, it's fascinating to me. But again, I think that we have to have people who do a lot of this. This is complex stuff. We do it in our hospital. We have 14 interventional cardiologists, 1 or 2 can really do it well. It's not simple.
Those are all great points. So I think with that, we're going to move on to the next part of this symposium and specifically talk about some lesion subsets. We'll start first with in-stent restenosis, and Dr. Shiv Kumar is...
No,
Oh, we'll do him
Dr.
later.
Srinivas Kumar.
Srinivas Kumar is going to speak first on left main disease.
Yeah, morning everybody. Thank you Ajay for Dr. Vijay Trehan sir for leading these discussions. A lot of interest, and though some special operators who have intense interest do this, but a lot of service is happening to patients. All of these were neglected before and used to die. Now at least some of these patients are saved. And I try to save some time, because my request again, both of you, is we should be trying to finish by 11:45, so that 12 to 12:30 will be NIC data presentation, where I request all of you to join, and the next part of the chip regarding CTO can be have after that data presentation. So I'll try to save some time. And left main interventions, I chose to speak. So basically, this slide brings best wishes from the hospital. I'm also proud to present our team of cardiologists, FACS Professional Services. There are about 27 cardiologists, 3 cardiac surgeons. And heart team approach is one very essential. When Pratap was presenting cases, I was checking with him. If all of us are together in the lab, it's again additional strength, though you're the main operator. The supportive things, many of the things are taken care by our colleagues. And especially when you're dealing with such complex high suspect subsets, it's very important to have good assistance and always call for help whenever additional help from surgeons or other things are required. Coming back to our topic, left main, this slide you must have seen in many places. Left main is not one single entity, be it shaft, bifurcation, and whenever it involves a bifurcation, that's where a little more problems. We traveled a long distance from doing procedures in emergency bailout. Now we offer this as elective therapy. I think yesterday I heard Ramesh and others speak that shaft and ostium probably need not have heart team approach. Also, bifurcation is one where it needs discussion. But I feel probably because in India still it's always our duty to keep part of surgeon in all discussions, it's better. So from this earlier scenario, now with the advent of this better imaging facilities which we have, many of us keep asking whether the IVUS is better or OCT is better. Each of it has its own advantages and disadvantages. I am not going into details of it, but it is suffice to know the minute details of stent apposition and stent struts coverage and all that to be seen in more greater detail with OCT, whereas stent lumen sizing, stent sizing appropriate from media to media, all that are better with IVUS, and any deeper structures probably you see it better. What we need to understand is OCT sees from endothelium to endothelium. That's how the sizes which we get are slightly less compared to IVUS. As if you understand this, then probably you're okay, whatever modality you're using. And the additional things which we learned about the pathogenesis of these various plaques, that's where the OCT scores particularly to decide in what sort of therapy we're offering. Maybe it's more relevant for acute ACS type of scenarios. I'm surprised in our country, even the data when we were analyzing, even acute MI patients, 1% of them had involvement of left mains, the patients who presented. So sometimes it is useful to have this. And this is the comparative chart which shows advantages and disadvantages of OCT and IVUS. I think if you can have both, there's nothing like it. But always, if you have to choose one, then depending upon which modality you're comfortable with, probably you can plan for that. The places where imaging helps, it has, I think some of the seniors should excuse me. For the sake of everybody, I'm covering it. Pre-intervention to size the lesion and the length of the lesions, and then probably the most important place where the imaging plays is to assess whether the pathology is only limited to left main or is extending into LAD and LCX. Because again, when the plaques extending to ostium of LAD, LCX, we need to tackle them accordingly. And then probably true vessel size estimation with selecting the right size of the stent, that's where it scores. But often we see that in post-intervention phase, we use this more common, and most of the times we try to save number of stents where the proximal optimization is being done. That's where this imaging helps, and we need to achieve a minimal luminary of more than 7 at least. But again, depending upon the sizes of the daughter vessels you decide. Then diagnostic modalities are imaging. We say less than 5.9 was thought to be significant. Now there is no controversy to say that IVUS imaging or OCT guidance compared to angio has enough data that mortality and the events are much less when the procedures are done through image guidance. This is meta-analysis. Not going to details of all this. The volumes of data which has come that both death rates and MACE are significantly less with image guidance. Ajay has reviewed this extensively. It's always good, and we should be thanking Greg Stone for making this. We have now a strong evidence to say that what we are doing is right. Excel study with 2,900 patients proved that it is good enough, unprotected. Only thing of caution what we need to notice is about 70% plus procedures are done through imaging. And here, initially, actually, it appears to be that PCI has scored over CABGs in the early part because of less incidence of strokes, and that's a dreadful complication. And the TLRs are not included, and then that's how strokes somehow had little more with surgery. Initially, they scored better. The graphs are equalizing. We hope that it will continue further for good of our patients. That's how Excel concluded that if you take care of the technique well, probably you can offer it as a therapy of choice too. The Noble study, which is again driven by surgeons, initially it was thought that two trials are opposite to each other, but basically because stents used and probably the long-term analysis of 5-year data, which is then probably showed that PCI has a more revascularization rates. That's where is the main difference between surgery and PCI. Coming back to the technique, basically left main strategizing, you need to see what sorts of scenarios you're dealing with, and initially patient should be evaluated as a whole, and not only the lesion. If it is what type of scenarios you're dealing, high risk, you could have some time to cool the patient, probably plan the procedure well, have alternative strategies, give proper anti-platelet regimens to these patients, and then see whether any contraindication to that. All that is important. Coming some tips and tricks for youngsters. Basically, we tend to use femoral a little more commonly than radial whenever, especially the bifurcation where we need, we are planning for 2 stents. But nowadays, if you are using all new material, we can still manage using through radial also. IBP support, a lot of discussion about impella happened, especially when there is LV dysfunction associated, and then that's where you need to have support. But many of the times, we keep doing it if the LV function is normal. And then 7 French guides are preferable if you are planning 2 stent strategy, especially the distal bifurcations are involved. Then we prefer more extra backup support guides. Whereas osteal lesions, if they're there, then probably JL guides, Judkins could be preferred to avoid more dissections happening. Wiring, whichever workhorse wires you're using, you could, whichever ones you're comfortable with, you can use. Generally tend to avoid floppy wires. Pre-dilatation is again very important. As usual, anywhere, the bed has to be prepared well so that stents expand well. And then there's no discussion. Initially, there were some large size stents. Bare metal also could be used was the thought. Now it is beyond doubt proven that DES is the one which is to be preferred. And now it's almost become imperative that bare metal stents are not available almost in the country. Then preferable to do with image guidance. This is basically the formulas which work out to the Morris formula, which you see the calculations for this. I think all of you by this time are aware. The minimal areas what we are supposed to get, 5, 6, 7, 8, what is mentioned. I feel it should be the minimal thing which you should think that if you can achieve better areas than that, more than that is described, the follow-up results could be further better. I think before I close, I would like to show 1 or 2 cases. Basically, I selected one case of osteal left main and one of crossover type of thing, and then one of osteal LCX. And then this is a 45-year-old female, confused with just hypertensive, dyslipidemic, has recurrent chest pain. It was thought to be non-cardiac outside, then CT angio done, showed very tight left main disease. If you see this, we had some information about osteal left main, so that's how we selected with the JL catheter. As you hook it, it used to get damped. So we're mentally prepared with ourselves, then probably we took 1 or 2 check shots and then went ahead with the procedure. And it's very important to always easy to prevent complications rather than tackling it. So because we had idea before of suspected osteal left main, then we could do it. And then once we saw, then there's also some disease in LAD. It's always better to take 2 stents if possible for differential sizing. But for various reasons of other issues, this is becoming less relevant in today because of decrease in stent prices. But previously we used to tackle that. We wired both LED LCX, pre-dilated ostium with the earlier smaller sized balloon, then the bigger sized balloon. Then we took a longer DES compared. And for the osteal placements, I feel you always check in the elevocranial view, because caudal view sometimes you mistake the ostiums. And then initially done, the stent looks okay, but as we thought, then probably proximal portions needs optimization. We dilated with the 4x12 after rewiring through the LCX through the stent, and then we did a OCT. Obviously, of late we started liking OCT more and more because of clarity of imaging, but there should be some trouble, could be some troubles in osteal imaging because the catheter has to be kept outside and while imaging. That's where again osteal locations IVUS could score a little more over OCT. Then in this patient we did, and then initially if you see the LAD stent, the position was all right, but left main if you see the Mala position seen very clearly. Then we taken again 4.5 into 8 balloon, dilated it further, then tried to study again with OCT later, then stent now is well opposed. And if you see the final MLA, it's around 11. So we were happy and the patient did fine. This is a final result which we got. Yeah, you remember that first which we showed osteal as very tight stenosis. Now it is a good looking osteum and patient is doing fine. Another 53-year-old male patient presented with unstable angina. Here if you see, he has, this is a little more common situation where osteal disease is there and a mild disease in the osteum trifurcation. If you see calculations wise, it comes to be syntax of 26. Then probably we could, patients were discussed and then we did a stenting to this. Then most of the times, you can get away with crossover stenting. Pre-dilated with 2.5 balloon, then placed a stent. Then after stent deployment, that is, angiographically it could look okay. But when you studied through OCT again, there was obviously in proximal portions it has to be underexpanded, post-dilated with 4.58 balloon, and this is seen again through OCT and then Vela post-stent. That's the final result which you see. The another case, I'll just close in another minute I think. Then 46-year-old patient presented with angina and exertion. You see tight L6 disease. Many of the times we are always worried how to tackle such L6, tight L6 disease. And there is also, now if you do imaging, then you find out that LAD also has involved, then probably you're more comfortable following a bifurcation stent strategy. With here, when LCX is involved, probably whichever angulation is difficult, we try to position and treat that first. And LCX was predilated, then we took a stent into LCX and 2.75 to 18. Then other important caution is you need to place your balloon in the LAD left main because some of the struts protruding. Unless you crush them immediately after deployment, there could be problems in taking the stents in. So that's how we crushed it. And then we have taken a bigger sized stent from left main to LAD. Then I feel again minimal small size stent rewired and balloon is dilated through stent struts. Then after putting this is the final kissing. Whenever you are doing a two-stent strategy, I feel final kissing is more relevant and more important. And if you can confirm it with final imaging, that's the best. So that's how this is the final results which are seen here, and patient is doing fine. We have come a long way from contraindications to now class 2A indications. Why we do all this struggle is because of this. We want our patients to enjoy immediately after the procedure rather than being lines. Our surgical colleagues sitting here may not like it, but they're also innovating, coming with minimal access procedures, things like that. But if we given a choice to patient, always patient should prefer less invasive stenting, and that's how they have the advantage. We deal with the patients first, but always heart team approach and really thinking about what is good for the patient and doing right for the patient is important. And in today's era, I feel whenever the bifurcations involve syntax scores being on the higher side, it's more and more imperative to involve the surgeon in discussion, and probably latest generation stents with imaging guidance. Now we could give this therapy, offer these patients as a treatment of choice. This came from even Eugene Braunwald, who is supposed to be father of cardiology. He himself said that we have reached a stage to offer this therapy to these patients, this life-threatening disorder, confidently, provided we take care like how it was done by all the Excel apparatus using imaging guidance and expertise. Thank you very much for your patient hearing.
Thanks so much. I think we're going to try to keep moving in the interest of time. So it's a real pleasure to introduce Ziad Ali, who's here for the first time in 26 years, he told me, to come back to India. He just got off the plane, endured crying babies to be able to show you. He'll have several talks at this meeting on OCT and imaging as a whole. So it's a perfect dovetail off of Srinivas's talk.
Ajay, thank you very much. Yep, that's right. First time in 26 years back to India. It's a pleasure to be here. I must say I feel at home. So, so I'm going to talk to you perfectly, I think, follow up on what Srinivas just talked to you and focus specifically on the utility of OCT imaging in complex and high-risk PCI. So the first question we have to ask ourselves, particularly in an economic situation such as we are in here, with the cost of the catheter is very high, and in fact the cost of a drug-eluting stent is lower, which patients actually benefit from imaging guidance? So this is a 46-year-old with hypertension, hyperlipidemia, and CCS class 2. He's direct stented with a 4/15 everolimus-eluting stent, and this is the final result. Is this patient likely to benefit from intravascular imaging? Well, let's take a look. 2 contemporary trials, including our own, have shown that once you reach a minimal stent area of 6.8, your risk of target vessel failure starts to reach approximately 2.5%. So if you perfectly expand this 4.0 stent, you end up with a 12.6 millimeter squared area, far off to the right and unlikely to benefit. Even if you expand this to 70%, you end up with an 8.8 millimeter squared area, and as a result, this patient is unlikely to benefit from intravascular imaging. But Ajay has been intricately involved in the evolution of this concept of complex, high-risk, and indicated patients, and we've somewhat divided this simplistically or dumbed this down into high-risk clinical, high-risk angiographic, and high-risk hemodynamic features. And I think it's clear that these patients are undertreated, but it's also that these patients are the ones that benefit from imaging guidance and are suboptimally treated when they are treated. So the first question you have to ask yourself in these situations is, which patients are at risk? So if you look, this is a recent analysis from the Cardiovascular Research Foundation of 13,500 patients from contemporary drug-eluting stent studies, which shows which patients are most likely to end up with a target vessel failure. And you can see it's all of the things that we know on a day-to-day basis. When the patient comes into the lab, you know that diabetics and long lesions and bifurcations, severe calcifications, CTOs, ISRs, left main, and end-stage renal disease and CKD are more likely to lead to a target vessel failure. But here's the evidence. And actually, this concept of CHIP, unfortunately, is not dichotomized. It's overlapping. There are diabetic patients with bifurcations who also have a CTO, which actually creates a synergistic effect. But often we come up with the question, why do I need to image? The stents are cheaper. I have optimal results anyway. What's the purpose? Well, meta-analyses actually show very clearly that even in the most complex and higher risk patients, that there is a clear-cut benefit in terms of major adverse cardiovascular events, as well as target vessel failure and stent thrombosis and target lesion failure, etc., specifically for patients who are complex and high risk. So let's focus specifically on those categories that are high risk. This is a 36-year-old female with poorly controlled diabetes who's on an insulin pump. She's morbidly obese, turned down for cardiac surgery because of her morbid obesity. And I asked myself, in real life, this is a real case, and one of my closest colleagues is working in the room next to me, what size and length stent would you place in the LAD? And my original plan was actually to put a 2.75 millimeter distally and a 3.5 millimeter stent proximally, and I toyed with the idea of using intravascular imaging, but it was quite late at night, and my colleague who was in the other room said to me, it wasn't Ajay, by the way, it said, you know, maybe let's just get in and out. Let's just get this case done. So here you can see that in the end I ended up performing OCT, and where I'd planned to put a 275 distally, it turns out the artery is almost 4 millimeters. And as a result, I would have been grossly undersizing my stent. And at the proximal reference, you can actually see that this artery is almost 5 millimeters. And this is the major benefit of intravascular imaging. It allows you to put a tailor-made suit into the artery instead of a suit off the rack. But there's more to this. We not only were sizing this wrong, but now we learn with precision PCI using OCT that the length from normal to normal is 49.2 millimeters. So I know I need a distal vessel is 3.8 millimeters and the proximal vessel is 5.5 and the length is 49.2. Which stent should I choose? And can OCT help me? Well, let's take a look. Using this very simple technique by turning on this thing called bifurcation mode, you can actually ask the OCT to identify all branches that are more than 1.5 millimeters in an automated method. What does that allow you to do? It allows you to determine exactly where these branch points are and therefore determine that a 22 millimeter stent will lead to double jailing of a side branch, as will a 38 millimeter stent. Instead, what you can do is perform a tailored therapy and identify that a 33 millimeter stent distally will land both distally and proximally into a completely normal segment of artery, and an 18 millimeter stent proximally will also land from normal to normal. Critically, this also takes into account the dynamic range of each of the stents, because a 3.5 millimeter stent cannot be taken up to 5.5 millimeters. And actually, these stents have dynamic ranges which should not be overcome, after which the polymer and drug become unreliable. What about non-ST elevation ACS? Another case where one of my colleagues was on the telephone with the surgeons referring this patient for CABG following identification of this left main lesion, where we actually convinced them to say, well, let's perform an intravascular imaging because of a hazy appearance in the ramus. So, quite interestingly, you'll note that the minimal lumen area from a healed plaque rupture in the left main coronary is actually 9 millimeters squared, completely stable and unnecessary of treatment, certainly not with CABG. And in fact, the plaque rupture is a relatively straightforward lesion in the ramus intermedius, which was treated with direct stenting. What about bifurcations? How can intravascular imaging help with bifurcations? This is a Medina 111 and planned treatment with a two-stent strategy. And you can see that following intravascular imaging, even with intravascular imaging guidance, but with an angiographic recrossing of the side branch, there's a waste on the side branch balloon. And the OCT tells us very clearly that while the main branch vessel is fully expanded, 92.7%, this feature called the rendered stent actually allows us to identify the side branch with intricate detail. And by turning on this 3D bifurcation mode, we can see where the problem is. The problem is that the strut, the wire has crossed through the proximal strut instead of the distal strut. And so this is problematic. You may ask yourself, does it really matter? A lot of us talk about this, that the wire has gone through the wrong strut, but is there a clinical benefit or is there a biological benefit? Well, let's take a look. On the left side, you see the pre-OCT where the wire has access to proximal strut, and the right side, there's rewiring under the distal strut. And let's take a look at what the OCTs look like between the two. The proximal cell strut following kissing balloon inflation is on top, and the distal strut is on the bottom. You can see that the orifice of the side branch is clearly identified by OCT. There are now no longer any struts crossing the orifice, and you have a nice circular carina. Particularly in bifurcations where the risk of restenosis is highest at the side branch, this is of major benefit. And in the end, not only is there a good angiographic result, but also evidence from intravascular imaging that you performed an optimal PCI. What about restenosis? This is another high-risk category with a hazard ratio of about 1.88. Now, angiographically, you can see that both of these lesions have the same phenotype. They appear to have an in-stent restenosis. However, the mechanism of restenosis is completely different. On the left side, this is an underexpanded stent, and on the right side, this is neointimal hyperplasia. There is no way to be able to determine this from angiography, and if I would put my hat on anything where intravascular imaging is an absolute must outside of the left main, it really is for in-stent restenosis and stent failure. And it turns out that this underexpansion is actually very common. In the first year following stenting, it's somewhere approximately 20% compared to 80% neointimal hyperplasia, and as time goes on, this continues to stay with similar numbers. So how can this guide you? Well, you can see that the OCT provides you automated measurements. You can see that the minimal stent area is 2.6, and there's minimal neointimal hyperplasia. So the treatment is guided by the OCT, which of course is simply a high pressure balloon. The last thing that you want to do in this situation is land another stent. But on this situation, it's completely the opposite. You still have a tight lumen stenosis. However, in this situation, you can see focal neointimal hyperplasia and identify predominant mechanism being tissue growth. And then rather than stenting the entire segment where we already know the risk of restenosis is high, we actually perform a very focused and targeted treatment specifically to the site of underexpansion. Ajay spoke to you earlier, or will speak to you next, about the impact of coronary artery calcification on long-term clinical outcomes, but I'd like to give you this important anecdote. In the Prospect 2 study, if we performed a procedure in the LAD and found in the non-culprit vessel calcified or lipidic plaque, the lipidic plaque cohort did significantly worse, suggesting that the calcified plaque provides a stable phenotype unlikely to lead to plaque rupture. However, as soon as we put in stents, this ratio goes backwards. All-cause death goes up, target lesion revascularization goes up, stent thrombosis goes up, and major adverse cardiovascular events go up. And put simply, there's only one explanation for why this is. And the explanation is that we are implanting the stents into severe calcification without appropriate vessel preparation, leading to stent underexpansion. How can OCT help? For the first time, we provide criteria by which you can determine which lesions may be treated by simple lesion preparation and which lesions need to be treated by a more complex lesion preparation, such as atherectomy. For example, this simple strategy, which divides a scoring system based on the following important parameters: a calcium angle of more than half of the artery, a maximum calcium thickness of 0.5 millimeter, calcium length of greater than 5 millimeters, leads to a score. And as you can see, the greater your score, the more likely you are to lead to underexpansion. How can you use this clinically? Well, if you identify that you have a score of 3 or 4, you have identified a lesion which will benefit from aggressive vessel preparation, including atherectomy. Here you can see a pre-PCI OCT where the vessel score is 4, and we perform atherectomy, which leads to a guttering of the atherectomy device, thinning of the plaque down to less than 0.5 millimeter. After the atherectomy reduces the thickness, we do a high pressure balloon inflation and fracture this calcium right in the middle of the segment, leading to optimal stent expansion that would otherwise not be able to be performed. The OCT can provide you the information of fractures throughout the entire vessel. Here's a vessel following rotablation which shows multiple calcium fractures, preempting that I know the vessel is now ready for stenting. And you can highlight these different types of plaque fractures or calcium fractures throughout the vessel, understanding the plaque morphology at each stage. We have an unpublished body of work which is going on currently, which is the ability to predict which calcified lesions can be fractured with a non-compliant balloon alone. And as we showed earlier, a calcium thickness of less than 0.5 millimeter and a calcium arc of greater than 221 millimeters are independent predictors of calcium fractures. What does that allow you to do? Why do you really want to know this? Well, the reason you want to know is because it allows you to optimally expand the stent. This is stent expansion that's performed following the calcium fracture. Here you can see perfect and stent expansion with a residual area stenosis in the distal half of the stent of 0%, and similarly complete expansion in the proximal half of the stent. What else can OCT tell you? Well, of course, angiography can determine the presence of calcium. It cannot evaluate arc thickness and length, which are independent predictors of stent expansion. Here, for example, you'd be able to identify this large calcified nodule on the angiogram, but you can see that the balloon result of this is simply displacement of the calcium away from the balloon and the leading to a large dissection. How can you perform your post-procedure assessment? It can be performed extremely rapidly to look for problems with the stent, such as tissue protrusion, major malapposition, edge dissections, and of course, expansion. We can also use this in CTO PCI, particularly after the wire has crossed. This is a reverse cart case in the main LAD, where we perform a post-PCI OCT and identify excellent stent expansion. But the OCT in this situation also tells us not to perform any more therapy, as there's a large aneurysmal segment in the subintimal space, and high pressure post-dilation in this position could be problematic, and as a result, the patient was discharged and brought back 3 months later for optimization of the stent. What about the newest and latest breaking? This is non-contrast solutions for OCT. I will leave you only that one of these images is with contrast and the other is with a non-contrast solution. So there is the future which has the ability to perform OCT without using contrast. This is a live case from Columbia Presbyterian Medical Center where there's a zero contrast PCI. Here you can see we're performing OCT without using any contrast, using a non-contrast solution with exquisite resolution, providing us all of the details that would normally be done with contrast. You can see that we're able to identify accurately both the distal reference measurements, the proximal reference measurements. Therefore, despite us using not a single drop of contrast, we are able to perform and plan for our PCI. The stent positioning can be performed using the angiographic co-registration with OCT. The stent can be placed precisely within 1 millimeter of standard deviation. Angiographic post-dilation is performed, and then following this, a post-PCI OCT, again without a single drop of contrast, shows that we can perform PCI that's optimal with full stent expansion and no edge complications without using a single drop of contrast. Here you can see that the distal stent is fully expanded, being more than 90%, and in the proximal half of the stent, again, perfect expansion. We described this in 2016. This was our first case. We've now performed over 100 PCIs without using any contrast, and hopefully be able to present this data to you very soon. I leave you with the idea and concept that we are not going to leave you with unanswered questions. Illumian 4 is a large multi-center randomized controlled trial which will randomize between 2,500 to 3,500 patients with exactly those characteristics that I described to you for the patients who are the most likely to benefit from intravascular imaging. I think we all agree that stenting a simple right coronary artery lesion with a 4.0 stent is unlikely to need intravascular imaging, certainly for the cost of the catheter that it is in India. But now we're talking about patients who likely have a significant benefit from intravascular imaging, and there's much more of a stake. As you can see, we're including only complex and high-risk patients, and what will perform OCT using a very specific protocolized algorithm or randomized to angiography and standard of care. Critically, for the first time ever, we will have a clinical endpoint which includes 1 to 2 year rates of target vessel failure, as well as a post-PCI minimal stent area. And I leave you with this last slide, which shows you that all of the questions that you have as to who is the most likely to benefit from intravascular imaging, we are performing this trial to answer these questions to provide the optimal treatment for our patients. Thank you very much.
Z, that was a fantastic talk. I know you have to run to the other arena to chair over there, so so go and do that. I think one of the key things, and when Ziad's here, he's going to go through in a step-by-step fashion, not only during the talks, but also in the booth area, specifically how to use these measurements, because it's a little bit different than IVUS. At the same time, there are a lot of automated things that make it a lot easier to use in some respects. So I think definitely take advantage of the opportunity for him to be able to show this to you. And he lives it in his daily practice every day and has taught a lot of us as well. So thanks so much. That was fantastic.
Thanks very much.
I won't let you go
He's not gonna let you
unless
go.
I ask you a question. Because if I look at it, the CTOs, calcium 1/3, diabetes 1/3, ACS 25%, bifurcation again about 20-25% at least, ISR 5%. If you take them together, I think almost any patient will have one of these characteristics. So now that the contrast issue is also not there, you are showing beautiful images. Let me know which are the cases in 2018 which you will or you can permit me to do without an OCT, cost not being in consideration.
Well, I think if cost was not a consideration, then there's no reason not to use imaging in every case. And while I'm a major advocate of OCT, I'm also a major advocate of IVUS. I think that the benefit comes from intravascular imaging. I do believe that OCT has specific advantages as it's precision and it doesn't require any guesswork. But if it was my parent on the table, I would want an imaging guided PCI, economics outside.
I quite agree with you.
No, I 100% agree, and I think the best way to answer that question is that how many of you would want your own or your father's or your mother's LED stented and feel comfortably with doing it with no imaging versus the ability to have it? And it's almost a rhetorical question. I think everybody would want it. So, awesome. Thanks.
Thanks very much.
Sir, one question, please. In a non-contrast media used for OCT, can you tell in depth about what is the mixture of that low molecular
I think you
weight
can discuss that because we all have had some experience with Dextran with some beautiful
This is
images, but I
definitely
think
not
It's
Dextran.
not
But
Dextran.
I think we have had images proximally with Dextran, but the details about what is being, I think you can talk to him later.
Thank you.
Thank you.